the QEIC, which is now the UMKC Healthcare Institute for Innovations and Quality, has been supporting these forums as an opportunity to engage in a dialogue in our community to understand a range of different challenges facing healthcare today, and to bring the perspectives of multiple different experts to weigh in on a given problem. Today we're talking about supporting workforce well-being and performance, which, as everybody knows, under the crises of COVID and now with so many of our workforce members getting sick themselves, has been an incredible challenge. And we are very, very fortunate to have a star-studded group of presenters. And we're going to start with the research perspective, which will be presented by Kim Kimenow, and then we will talk about a national perspective. We're very honored to have David Baker presenting. We'll be talking about the healthcare perspective, and we're very excited to have Heidi Baum and Lynn Murphy present. And then we will take the perspective of a particularly vulnerable component of our healthcare delivery network, which is the qualified health centers. And it's just an honor to have Will Franklin present. So the first presenter is going to be Kim Kimenow. And as you know, a lot of what the High IQ QBIC initiative has been is about bringing together multidisciplinary teams to share expertise and to be able to implement new strategies for delivering care. Kim Kimenow, I've known for over a decade now, is the Chief of Staff and Strategy for the Executive Vice Chancellor of the University of Missouri Health Affairs System. She led and did a remarkable job in coalescing the Frontiers Initiative to engage multiple disciplines and team members, including providers and patients, to work together to help generate new and important knowledge. And she is a medical anthropologist by training, who really brings a unique lens to how sort of people can work together and how the whole can be so much greater than the sum of its parts. And so I'd like to thank Kim very much for presenting and turn the mic over to her.
Great, thanks, John. Hopefully I'll be a little luckier than Stacy with sharing my slides. We'll see.
I'm back all, but yes, thank you.
There we go. First of all, thanks again, John, for that kind introduction. Thanks to this team. I feel like I'm reconnected with good colleagues in Kansas City. And I have one slide, so you're going to get bored just looking at one slide, but it will keep me grounded and on time, because I think I could probably talk about this topic for an hour. And I am so excited about listening to the other speakers as well. What I've learned, and what you will learn the more you look at team science issues and the science of team science, is that you're going to learn something new every time you talk across disciplines about how to run teams and what teams do to accelerate performance in the space of research. So that's what I was asked to talk about today. So I'm going to leave you with kind of 6 key points to just spend a little time on, and to illuminate a couple of articles that I think are really worth a read. So first, we know that the science of teams has been around throughout our training, likely. We know that teams work in various, very different ways. Lots of social psychologists and other social behavioral scientists study teams. But there's been a trajectory in academia, certainly, where back in the days when rocks were formed and I got my PhD, you had to have a solo authored article. It was the currency of the land, that you had to demonstrate coming out of your PhD program, you could write a paper all by yourself. That sole authorship model is really gone. And we work much more dynamically with a group of individuals, typically on teams. So this whole notion of academia and research really embracing team science has changed, certainly in just my professional career. What we recognize is the breadth of expertise is often the currency of doing team science. So first of all, before I even go any farther, I want to point you all to a group that's called the Science of Team Science. When I have a second, I'll shoot the website to you in the chat box. But it is a really dynamic resource that has, for example, a Mendeley desktop library that was launched in 2013 on the science of team science, really rich resource. They have a listserv that is quite active. And there's an annual meeting that is like one of the funnest meetings to go to, because you will meet folks doing team science from across the spectrum of engineering, fine arts, humanities, medical sciences, engineering. It's just an amazing group. So I highly recommend, if and when we get back to going to conferences, it's a great one to join. And it's largely through my association with that group that some of the learnings and points I'm making today come. So I'm giving all the credit to the team of researchers studying team science. Okay, breadth of expertise is the currency of team science. So what this means simply is that when you get a bunch of really smart folks in the room, that's great. But when you get really smart folks in the room who bring their lived experience, their community focus, their academic expertise, their theoretical frameworks, their academic contributions, when you have a breadth of expertise, you truly can spark and synergize new kinds of perspectives in looking at a problem. And frankly, I don't care what the problem is. It could be looking at uptake of a cancer therapeutic. It could be engineering a smarter piece of software. When you get diverse users and thinkers together, you truly have the core components of what team science is all about. However, like my mother told me long ago about wearing makeup, too much of a good thing is a bad thing, right? So you can have the too large a team, too much diversity, that actually grinds teams to almost a halt, because you've got too many leaders, not enough followers, too much sub-dissension within a team. And so thinking about expertise and the breadth of expertise needs to be done not so much from, I need one from column A and B and C and D, but actually the components of the expertise that come to the table to work on a problem really need to be closely examined. So more isn't better, more is more. And I'm going to talk about what that more looks like in just a second. But too large, too broad an expertise may cause divisions within a team that need to be attended to. Okay, my third point. It's wise to remember that we tend to think of many hands make light the work, that maxim and proverb, but you also have to be aware of something called social loafing, which is like one of my favorite terms, because I do it all the time, and I guarantee you do as well. So one of the best examples, does anybody know what social loafing is? Have you heard the term before? Good. Well, it is this very interesting, it's also called the Ringelmann effect, that was established in the 1920s, 1930s, where the additive benefit of working on a team sometimes is diminished by being a team. So this was tested in a very unitary task where people were asked to pull on a rope, and they measured the force of that pull on the rope. And what you find is, as the number of people on the team increase, your individual contribution may actually wax or wane. It might actually decrease. We tend to think of teams as being additive, like everybody's in it and let's all join together. We have a team expectation of increased effort, brings group morale and elevates the work, but social loathing happens throughout teams. Therefore, you need to look at whether a task truly is an additive task for a team, or if it is complementary or requires different contributions by each member of the team. You know, pulling on the rope, everybody's doing the same thing. They're pulling on the rope. But in other tasks, you need, I need John to come to the table as a cardiologist. I need Stacy to come as with a research hat. I need different people adding different things. Then you have an additive component and you avoid social loafing. The article is by Latané in 1979 that summarizes this really well, and I can share that as well. Okay, so I've already talked about the breadth of expertise to accelerate science, but I also want to talk about, okay, so what's the right number? And you'll find that the right number usually is quoted to be between 4 and 9, between 4 and 9. So I'd love you all to use chat box and just vote your number. What's the ideal team size? Is it 4, 5, 6, 7, 8, or 9? I'll give you a second to do that before I tell you the answer, because there is an ideal number, but just go ahead and share. That'd be great. I see the chats are increasing, so that's wonderful. The point here is that, much like my earlier point about the breadth of expertise, too small a team, and you don't really have a team. You know, a team of 2 is pretty tough because you both point at each other, right? But teams greater than 9 tend to lose capacity to execute and accelerate their performance. So there truly is an empirically derived right number, and I'll tell you that number is 6. So I'll leave it at that, and you can all argue among yourselves about whether that makes sense. I'll leave on one additional point, and that is that I'll argue for the field that I come from in terms of social sciences as being instrumental for team science activation and accelerating performance. Understanding how people communicate, and that's part of our discussion today, but how they work together, their work styles, their theoretical models and approaches to problem solving. A lot of understanding the dynamics of a team require you to be able to step back and look at these social dimensions of how people are interacting as well. And so while I've said breadth of expertise is really important and too much is a bad thing, I'll argue strongly that an element of a good team will have someone trained in social and behavioral science. They will be able to help maximize the capacity of the team by being able to contribute the social IQ, the emotional components of working on a team that I will, again, forward to this group for their consideration to think that that is a linchpin factor in team performance. So I'll stop there and turn it back to you, Stacy.
Great. Thank you so much, Kim. That was wonderful. 6, huh? Interesting. All right. And again, I'm really sorry, everyone. I switched devices. That seems to have helped. So I'm glad I'm back. So we'll now go to our next speaker on the agenda, who is Dr. David Baker. And he is Senior Vice President at the American Institutes of Research and formerly at Impact International, which was acquired by AIR. And he provides oversight for AIR's health division, which consists of over 200 staff with expertise in health policy, patient and family engagement, value-based reimbursement, Medicare and Medicaid, program evaluation, and knowledge translation, amongst many other things. And he's a nationally recognized expert in team performance, training and measurement, and the role of teams in high-risk industries like healthcare, the military, and aviation. He's known for his work on the Agency for Healthcare Research and Quality's AHRQ, the Team Step program, which has been implemented in healthcare organizations around the world. And I guess 2 of my former employers being AHRQ. And then I also worked under Dr. David Baker's leadership when I was at Impact. So it's so great to have you here, David, and the floor is yours.
Okay, so I'm going to share first, and let me reorient everybody just so I can see folks. And I assume you all can see my slides and can hear me.
Yep.
And the only recommendation I have for IT things is I have well, when the pandemic started, he was 16, now 18-year-old son who loves technology. I gave him a credit card, and I haven't had technology problems ever since, but I'm a lot poorer. So he's my IT support. So we have all sorts of things in our house. We could power Baltimore probably, which is where I live outside. So I think that was interesting listening to Kim first. I'm going to take probably a little bit different perspective on some things about teamwork, but I think that's good. We'll be looking at this from different perspectives, but I think it has all a common core. So I thought Stacy gave a background of me and where I sit now, but just to give you some framing from my experience in teams and developing really what my work has focused more on team training programs, right? How to improve performance in different high-risk industries. So I started my early work when we were thinking about this 30 years ago boy, that just really hurts sometimes when you say those things, but we were working early on the US Navy's team training program for pilots, which is still in existence today, which is kind of cool. You can search OpNav instruction 3710 and you will find it. What we were looking at the time is what is the core skills that are important for aviation teams to be successful, and then how do you teach and prepare those teams to be successful? Because if you are familiar with a lot of accidents and things of that nature in the aviation industry, it's not a technical issue, it's a coordination or a teamwork issue. Then broaden that work. I worked with the commercial US carriers for a number of years through the FAA, focused on their teamwork program, which they instantiated in their training, right, into what's known as the advanced qualification program. So now pilots, commercial airline pilots, are taught technical and teamwork skills. I did a lot of work with United Airlines in particular about how do the check airmen then assess to make sure you're qualified technically to fly the plane, but also manage the air crew and serve as an effective team member in that crew. We also did a national survey at one time of 50,000 airline pilots about what they thought about their training. And of course, what Stacy mentioned, I was involved since the beginning with the AHRQ Team Steps program, which some of you may be familiar with. We did a lot of the foundational work, thinking about what the requirements are for successful team performance, the actual design of the curriculum, and the foundational components thereof. And then we did a long-standing follow-up evaluation of the participants in the program to see what they were using and what they thought of the training, as well as structured the national implementation of the program at the time for AHRQ. So just to level set, I'm going to spend a little bit of time framing what I think about what constitutes a team and teamwork. It's going to dovetail very nicely with what Kim said, and then give you a quick, brief overview of team steps. So team, from my perspective, in terms of number, that's an interesting fun fact. Never heard that before, Kim, but the thing I think about, what distinguishes teams from groups is interdependency. So we have a bunch of tasks and they are interdependent tasks. So that requires and demands teamwork or team process to execute that work. And most healthcare is performed in teams or delivered in teams. It's actually a complicated multi-team system when you start to think about it, right? Think about labor and delivery, where you have the bedside nurse, the physician who that person has to work with, you have the resource manager for the unit, coordinating beds, coordinating other resources that are needed and the like. It's a very complicated system that you can continue to think about in a very large scale that has to intersect. So what do effective teams do, right, in delivering or performing work? Well, generally they have a common goal and a shared understanding of what that goal is. They have members, if you work in an intact team, who can anticipate each other, right? You begin to know what's going to happen. If you think about intact situations, it could be a surgical team that handles specific cases. That's one of the unique things about healthcare, right? The team members are constantly changing. Communication is not the only thing that they need to coordinate, right? They learn to expect what's expected of a particular role and how that's going to unfold. They can adjust their strategies under stress. Right. And one of the ways they do that, and that's what I highlighted the last one, because I think it fits in this topic of wellness and dealing with work right now, is the key to teamwork, right, is backup behavior. Team members back each other up. We can think about how we redistribute workload around a task or a day in order to be more effective. And that's the benefit, right, of teamwork. In addition, we talk about communicating often enough versus communicating too much. They span boundaries, provide effective behaviorally based feedback on how to improve the overall performance of the team, or debrief, how is the team doing? And they understand what the roles of the team are and how those roles fit together. So there's different strategies then to produce effective teams. You could select the right people. There's a lot of mixed research on that. You could design the work so it facilitates teamwork. That has not worked well. What has worked well is you train team members in terms of what they need to know and what they need to be able to do to work effectively together. Team steps also is based on that, as well as this concept of providing some additional job or work aids to facilitate teamwork. The interesting thing about teamwork I've always found from working with different clinical teams and throughout my career is team members or staff generally know what to do. They think it's a good idea, but they don't always do it. And what's fascinating about that is then you get into the question of, do they need to learn specific skills, right? Or do they need specific tools to help them facilitate doing what needs to be done in terms of enhancing good team performance? So team steps, the key line here is this is a bunch of free resources. If you ever wanted to learn it or use it would be the more important thing to say. It's on the AHRQ website. It's completely customizable. I use these concepts in my work now as the senior vice president over the health division. I'm sure Stacy or Shanice DeMar is on the phone, also work with me, had heard me say before, and you will see some of these tools in terms of the work we do for delivering a project or a proposal. These are core things, right, that are important for being successful when tasks are interdependent, workload is high, and members have key roles in completing those tasks. So team steps, the way it's organized and the way it's been taught for the longest time, there was a large-scale national implementation. We actually, many years ago, worked with the University of Kansas Medical School because we looked at weaving some of this into the medical school curriculum, and they were interested in this at the time and provided some training. Basically, the way it's taught to master trainers, and that program unfortunately has sunsetted. It used to be free through ARC. There are vendors who provide this service now. Is the first day is taught all about the fundamentals. What are the core components of the program? What are the core skills? What are the core strategies? The second day really, and that is the hard work about team steps or any program that you're trying to do organizational change, right, is how do you introduce these things? How do you prepare people to implement them? How do you coach and give feedback? How do you measure to ensure that the change program that you're trying to put into an organization is successful? So this is our fancy graphic to show what the core components of team steps are in terms of skills. The core skills that, if you go back to that Navy program, we had 7 skills. Over time, we got that down to a fewer. And this is what we focus the instruction on: how to lead a team, how to understand the roles that comprise the team and how to monitor those roles so you know how people are doing and how that fits together, how to provide feedback and backup. How do you support your teammate, so to speak, in the delivery of care, and how do you do that effectively in a care environment? And then communication tools, which is the glue, right, that holds a lot of this together, because we do work through communication and support each other through communication in terms of this coordination element. This is a quick summary of the tools that currently exist in the curriculum that one could apply. So the yellow is the key here. We have tools, I'm sure many of you, these are familiar now, especially in the healthcare field. There are others that aren't on this list too, right? So SBAR is a communication tool. It's just a structured way to communicate. What's the situation? What's the background? What's the assessment and the recommendation, right? I'm going to cover a couple of these, but brief, huddle, and debrief. How do we know the plan, share the plan, discuss whether or not the plan worked? And then how do we give effective feedback? How do we raise things that we have concerns about, which is the cuss and to challenge? They're all in the curriculum. They're all available through that link should you want to look at them. So the briefing checklist, that's one I'm just going to talk about. It seemed relevant to the concept of workload and how the environment could change on a daily basis now with what we're dealing with COVID-19. Normally we have a staff of 8. Today we have a staff of 6, right? And so we need to adjust our plan that we would normally do and how we're going to accomplish the work. Let's get together and brief, right? Know the plan, share the plan, review the risk if we're understaffed. And we use this all the time. I say this all the time to when we're doing a proposal, right? Know the plan, review the plan, share the plan, review the risk. And if the plan changes, huddle and reestablish what the new plan is, right? Take the time to talk. Too often today, and in this virtual world, which is challenging, we're doing everything with the email, which gets to the second tool I'm just going to mention, which is this check back, right? We experience this, I'm sure most people, though not everybody's a Starbucks fan. When you go to Starbucks, right, you get the hear back, read back. You order your latte and the person on the other side repeats exactly what you ordered to confirm that in fact it's the true order. This stems out of aviation, right, from the hear back, read back of pilots. You know, turn to this heading, fly this altitude. That comes from air traffic control. The pilot repeats it back, right? Same kind of thing with medications, right? Administering during a trauma or instructions. These kind of communication tools and concepts are very important for facilitating teamwork. The second day then, after we've taught the tools and thought about what the content that is from the master training perspective, is the most important part. Thinking about what you're trying to achieve with the resources. So Team Steps is designed to solve teamwork-based problems. So defining what those things you want to change from a team concept by first assessing what the needs are. Importantly in this context, especially in healthcare, having worked for an 8-hospital system for a period of time, knowing if people are ready to endure the change, like right now with census so high, COVID and everything like that, might not be the best time to launch a big change or any change in an organization because there's a lot going on. Figuring out what the plan is, implement the plan, and then measure whether or not this worked. Okay, that's a key thing. The measurement does two things. It determines whether or not the plan or the thing you're trying to improve, that the tools you implemented were ultimately effective, but it also communicates that these things are important because it gives feedback along the way and shows that what you're trying to do with the implementation of, say, a tool, briefing huddles, SBAR, whatever, is a key thing. So it values that and helps promote that transfer of the change. This lays out the whole implementation timeline. Just to give you a sense, it's fairly complex, right? This is not simple stuff. It's an organizational change initiative. If you just skim through this, and this is a little dated, you have to figure out who's going to be responsible, why you're doing it. A clear aim as to what you hope to achieve is always critical, right? A clear, specific aim as to what this is going to look like when I've implemented a change is key to define success and know if you've been successful. Then planning out how to do that and measure it is the rest of this graphic, really. So in summary, if you didn't know about Team Steps, I brought you some free things. For research interest, there's also a research database along with this that justifies every skill that we updated within the last 5 years, right? However, right, this is really about culture change if you want to go down that journey. And my mentor, Ed Solis, who is one of the leading scholars on teamwork and team training, always says organizations get the behaviors they value and reinforce, right? So that's a key thing about what the organization, when you do these programs, right, communicate to the staff who are participating, and when you transfer it, how that's going to work, right? My friend always used to say the book he wanted to write was Overcoming the Effects of Training, because we can all think of going through a program and the first day on the job, especially when you start out, some senior person comes and tells you, forget about all that training stuff, this is how you should do it, right? So that's very key to think about the transfer environment and how these things are going to work. There are a bunch of resources. These are just curricula and different variants thereof. There's a version for office-based care, long-term care. There are videos for dental offices if you wanted to teach and have discussions about teamwork concepts. There's a rapid response system curriculum that we developed, which actually teaches rapid response systems and then embeds the tools into that strategy. There's some information if you had a sim center on how could you embed these concepts into simulation-based exercises. There's a research and evidence base. And then if you go onto the website, you can look at a bunch of webinars that we did over time that talk about people's experiences with this sort of thing as well. So it's like a lessons learned. Oops, go. I went one too far. Here is some research. Does this all work? That's always the question we got early on. The most recent thing that I had, which is a meta-analysis by Ashley Hughes and her colleagues. It was in the Journal of Applied Psychology. It looked at 129 studies focused on team training programs in healthcare. 75 to 85% of those are on team steps, and they found significant effects on people's reactions. Did they like it? Did they learn something in terms of knowledge, skills, or attitude change? Did it actually transfer to the environment? And did it impact clinical outcomes? Okay, which is the emerging part of this, where early on we didn't have a lot of that data to suggest. So this is my contact information. Always happy. Most of my time is spent managing the health division. So when Stacy called to ask me to talk about teamwork and team steps, this was very exciting for me. So if you ever had any questions, you are more than free to email me. Happy to discuss. I get interesting emails from all over the world about the Team Steps curriculum. So I will stop there. Thank you.
Thank you so much, Dr. Baker. That was great. And yeah, really informative. I mean, and I love the synergies with Kim's talk and yours about a lot of just the pieces of how effective teams work and how we can actually then implement those things into actual care. I think, you know, and especially with the work that the QVIC is doing, this really resonates really well. I mean, we're working, you know, across institutions and across disciplines. And then, you know, and that crosses, you know, clinical to stats to econ to, you know, process people. And so it's just, I think all of these are really valuable, you know, for us, but I think for everyone here on the call and wherever they're working. So thank you. So we'll now turn to our next speakers. We have a dyad up next. We have Heidi Baum and Lynn Murphy. And so Heidi Baum is a behavioral health program manager at the University of Kansas Health System. And she provides ongoing support and leadership for the complex behavioral health patient program, suicide prevention program, elopement prevention program, assault prevention program, and behavior response team to achieve their organizational goals related to quality and safety. And she's the co-founder of the KC Metro Workplace Violence Prevention Collaborative and the KC Metro Healthcare Quality and Safety Consortium. And that's how we came across, crossed paths in the beginning. And Lynn Murphy is a quality and safety supervisor at the University of Kansas Health System. She's been in quality and safety for 9 years and a nurse at the system for 16. And she's a co-founder along with Heidi of the KC Metro Healthcare Quality and Safety Consortium and is in a number of professional organizations as well. They both are. So we're really delighted to have you, this team working together, and the floor is yours.
All right. Hello, everyone. Hopefully you can hear me, and can you all see our slides? Okay, perfect. So we are really excited to be here. It was great learning from the two previous presenters, and we are going to talk to you about the virtual ties that bind, finding joy in the virtual workplace, because things have definitely changed since the COVID pandemic started. A little bit about our health system. We're a tertiary quaternary academic medical center. We have over 12,000 employees, over 4,000 nurses, and we officially now, with the opening of new units in our Cambridge Tower, we have over 1,000 beds. As you can see, we see quite a few patients every day. So today we're going to be sharing strategies that support employee wellness. We're going to be identifying productive virtual communication strategies and discuss virtual team building and collaboration examples. So hopefully this will be a lot of fun for all of you. And I don't know how many of you all became fans of the comedy series Schitt's Creek. So we have Moira here who, you know, we're asking, you know, have you been practicing self-care? And Moira might say, you know, in this time, and you'll have to excuse me for my lousy interpretation, I'm sure, but who has time amidst all this chaos? So I can't do a good Laura. But anyways, it's important that we find time amidst all this chaos to make sure that we are supporting our employees' well-being. So something that has certainly been getting me through this part, because many of us on our team have been redeployed to support inpatient operations or COVID operations. The pandemic is tough. It's been tough on everyone, but together we are tougher. So I think, everything we're talking about today is so incredibly important, because we couldn't do this without the great work of all of our teams. So we're doing a lot of things in our health system to support our caregivers. So what you're seeing on the screen now is what we've called the roadmap to resilience. And on this, it's spotlights programs available to our employees for their wellness. So the first thing is our employee assistance program. And we recently switched to a new one this January. And they actually are on site today at many different locations of our health system throughout the city, and tomorrow just providing some one-on-one support for our teams. Because, as I mentioned earlier, the pandemic is tough. It's really hard right now for our bedside staff. We're all seeing and doing things very differently than we were before, and we want to make sure we provide good care for our staff members. The next resource we have is Turning Point, and Turning Point provides a lot of training and courses for our staff as well as the community related to the 10 facets of resiliency. And then we have our HOPE program, which is the second victim peer support program. We have trained several staff in the organization to serve as HOPE coaches. So if an employee has some sort of adverse event that is causing them increased stress, then we can connect them with a peer mentor to talk through the situation and be a support to them. And then we also have through our human resources department, the It's About You Wellness program. And it focuses on the 8 pillars of wellness, and employees can participate and engage however they want to reach their wellness goals. So it really helps reach employees where they're at. So these are some organizational strategies that we have available for our staff. Another committee that we started actually last February is the suicide prevention for a resilient healthcare community team. So we call it the SPARK team. And really it's a collaboration between the health system and the University of Kansas Medical Center as a way to make sure that we are focusing on wellness and helping prevent suicide amongst healthcare workers. Healthcare workers are at an increased risk of suicide. And with the pandemic, the increased stress and the increased burnout, that increases that risk a little bit more. And so this team is really focusing on education and how to identify the warning signs of suicide, how to identify someone at risk, and how to talk with them. We are also supporting additional screening and resource utilization. We're really trying to transform the culture, really supporting that mental health is health, and there shouldn't be a stigma in asking for help. And so really just sharing with people how important that taking care of themselves is. We're also doing some community service programming as well as advocacy. And so now Lynn is going to talk a little bit more about the fun stuff related to the virtual environment and how we can make that fun and help support connecting our healthcare team.
Thank you, guys. Thank you, Heidi. I'm really excited to just share some fun things that we're doing at University of Kansas Health System and some philosophies we run our departments by. It's been amazing to listen to our previous 2 speakers with kind of meta ideas and big programs, and I'm going to pare it down a little bit and show some kind of small real life examples and applications, still using some of these concepts that they were talking about, which is really cool. So the first thing to acknowledge is that we're still people. We still crave human interaction. I personally am an introvert. I love my space. I don't like hugs. And I enjoy working at home, but I also do really enjoy just that time to enjoy other people, I guess, and other humans, and humans that aren't my kids and my husband, and that's not work related. So I think what we found is that we work a lot more when we're at home. It's a lot harder to unplug and a lot easier just to keep going, or I'm just going to log in for 20 minutes because, I'm waiting for my laundry to finish or my kids are doing this and I have 10 minutes. I'm just going to check my email. And so we do that quite a bit and it's really hard to unplug. So understanding how much is your work day, like what is that productive time versus that non-productive time. Acknowledge non-productive time is a real thing and build that into the day. So many times during the workday when we were all on site, you start, maybe you're putting your lunch away or you're getting your computer, you're waiting for your computer to boot up and someone comes over and asks how your weekend was, or how your kids are doing, or did you catch the football game or whatever, and you take that few minutes to connect. And it's really easy to lose that when we're all virtual, maybe working at home, or we have more just virtual teams, period. So we're spread out across the country or globally sometimes. So making it acceptable and encouraging some of that water cooler time. We accomplish that on our team through having a dedicated, we call it forced family fun. And it's an appointment on everyone's calendar. It's an optional thing. But it's a Teams meeting every day where we encourage people to come and take 15 minutes, even 20 minutes, 30 minutes, and just talk about non-work related stuff. And it's okay. And it's fun. And it helps with that connection. We've worked a lot together. Our team has been together for quite a while, but we're starting to add in new folks. And it's really been a great time to onboard those new folks and really make them feel like part of a team, since we're all at home, they're trying to learn, but to feel that inclusivity and that sense of belonging has been extremely helpful. Oh, next slide, please. Thank you. So we try and make our days not just full of meeting, right? Meetings that could be emails. We've all heard those things, but that doesn't change since we're virtual. We have all of these technology platforms. We have Teams, we have WebEx, we have Zoom, all of these different communication tools. Yet we're still so many times just meeting after meeting after meeting. So really looking at what are you trying to do, what's productive, what needs to include the whole group versus, this is still hard to believe, but picking up that phone, right? And just having a quick conversation rather than take away an hour of 6 people's times when really it could just be solved with a quick phone call, or sometimes even just an IM to ask an opinion, or hey, can you check your email because I never heard back from you. So looking at that, we have a lot of PowerPoint slides, making sure they're interesting, all those principles of good presentation. Encourage the fun during the meetings. We all, like today, I am fairly professional with my blurred background here and stuff, but sometimes it's okay to have a silly background. It's a conversation starter. It's an icebreaker. It's okay if your, dog pops in. It's like, oh, I want to see your puppy. Okay. It's, that moment of breath and fresh air and humanity, again, built into those things. And it's so easy for those just to fall by the wayside. And just using good courtesy, excessive multitasking. It's even harder now to, again, be mindful, be in the moment. When I have my email up here, I have my phone down here, I have 6 different chats and maybe 2 private chats going at the same time. Encouraging setting ground rules at the beginning of all your meetings, those types of things. Next slide. Thank you, Heidi. So this was a great example of our infection prevention and control team that they use. We've heard a lot already today about effective communication. And I truly believe that is one of the things that can be most effective at keeping teams happy, keeping them feeling fulfilled, taking away that fear of uncertainty, is to be effective communicators, right? And over communicate sometimes. So they have a really cool virtual huddle that they do about 3 times a week. They use SharePoint, they have their huddle board. This is where they can put their semi-urgent needs on there that they can discuss as a group. And then it's the patient information is blacked out here, but they can also use that as a communication tool for who's got infections, who's got lines, who do we need to really watch out for, who are we working up, and all that is right in front of them for discussion. And they do that, I think I said 3 times a week. There's their pictures. They'd probably kill me, but they're a great team. So next slide. And they do a really cool thing also with their team meetings with the whiteboard features. It's really nice. All of these platforms have like these, I don't want to say hidden features, but kind of bells and whistles sometimes. The whiteboard feature, they do like group team building exercises where you play like infection prevention related Pictionary and you break up into teams. And it's just like another kind of fun thing. It takes 10 minutes, but again, keeps us human. And especially in their field, they're very involved, right, and immersed in the pandemic. And sometimes it goes so far to take a step back and embrace that human side. Sometimes being virtual is actually easier than being in person. You don't have to worry about going from one end of campus to the other, which at KU, I mean, it can be a 10 to 15 minute walk from one end of the building 1 to, building 26 over here. Or we have people on all different campuses, and shuttles are such a pain in the butt. So some of that travel time and it's wasted time can be cut down. We set the same expectations for when you're in your meetings or you're preparing your work or your presentations or whatever. So that shouldn't be any different. But it really opens the door for these great opportunities to connect with other healthcare organizations as well. Before the pandemic, really, we had, if we wanted to talk to someone outside of our organization, we just used a conference call, right? You would like put in the number and you can't hear on the phone, no one's listening, someone's on mute, someone didn't get the handouts that were attached to the appointment and no one knows what you're talking about. And it was not helpful. It was not even worth it, right? It was kind of like, we'll have this, but you're not going to be an effective member of this team, unfortunately, many times. And so, with everyone virtual and you have the opportunities for cameras and the phones are better and everyone's just used to it a little bit more. I think by this point you should be. Then it's actually worked out really well. Our consortium, we had talked about many times, should we do this virtual or not? And we had decided not to at the time because we didn't think that we would have as good of engagement. And it turns out with this pandemic, we didn't have much of a choice, right? And so we did it, and it's worked out well. So if we are meeting at Olathe Medical Center and people from Liberty want to come, you don't have to worry about driving an hour almost across the Kansas City Metro. We get done and it's 4 o'clock, so now they're in rush hour and they don't want to come, right? Who wants to deal with that? No one on a good day. And so now it's a lot easier to get people there, and people all across the state. We have that opportunity now for them to call in, and so we still get to connect with each other and talk about the same problems that we're having. How are you dealing with this for Joint Commission? What are your quality people being reassigned to do? Like talking through some of these things together and learning from each other, and it's been a great experience. We're also, right before this latest surge, we were working on improving our RCA squared process. And, we've been able to connect with a lot of organizations from across the country that use RCA squared, and been able to, it's much better than a conference call, right? You've been able to actually see these people and you can share screens and share tools, and everyone is so happy just to talk to other people. So it's been really nice. Next slide, which I think is my last one. And an example of what we're doing at home, we have a Good Catch program, which monthly we celebrate a good catch within the health system that has prevented patient harm. Someone stepped up and stopped the line, and we were putting something in place to fix it. And we have since changed those meetings, those celebrations, to be virtual. And it's actually easier to get leadership there, to get our C-suite there, to get folks away from the bedside. They don't have to go physically go somewhere. They can just go to the break room or whatever, and we have the computer up and everyone can see us and we can see them, and everyone's so happy because they did a good job. And it's fun, and it's important to keep those fun things sometimes, and bring a little bit of light into people's life and say thank you, and let them know that just because we can't be there in person, that we haven't stopped recognizing your hard work and being able to physically say thank you, coming from leadership, coming from their manager, coming from quality, thank you. So it's been really a good opportunity, and we'll probably keep it up even afterwards because it's just easier. So I think that's those are all the examples we have. We talked through some of the wellness, some of our team building strategies, and different ways that we communicate virtually. So be looking forward to taking any questions later. Thanks.
Great, thank you both so much. That was really amazing. And I would encourage anyone, put any comments or questions into the chat for any of our speakers, just a reminder there. But, I thought those were really great. I love the like the virtual water cooler talks. I think that's a, really important thing, because I think that's an aspect of in person that we've all embraced so much. And I think having that on people's virtual calendars when they're remote, I think that's a wonderful idea. So thanks for sharing all of the work you guys are doing, and some great ideas with the team. And next, I'd like to turn it to Will Franklin, who is the president and CEO of the KC Care Health Center, one of the leading federally qualified health centers in our region. And Will has previously served as the CEO of People Health Centers, family of corporation, which includes Betty Jean Care People's Health Centers, which is another FQHC, and served more than 45,000 patients annually. And he's been in a number of other leadership roles, and also has been an adjunct faculty member in psychology at St. Louis University. And we're really delighted to have you, and the floor is yours, Will.
Well, thank you, everyone. And thank you to all the other presenters. Really appreciate all of the ideas. And I'm hopeful that I can speak to a little bit of the application of some of those ideas and the science behind what was presented earlier. And in addition to some of the things that KU is doing, I'm hoping that my presentation today can give you some ideas and thoughts around really engaging. I call this talk Caring for Caregivers, but internally we call it, taking care of the people who are taking care of the people. So it might help just to provide a little bit of context about KC Care and who we are. We're a federally qualified health center, as mentioned earlier. If you've been around Kansas City for a little bit, you probably have known us as KC Free at some point in our history. It's 50 years. We've been around now close to 51. We've postponed our 50-year anniversary gala that we were supposed to have last year to this year. But we treat roughly 20,000 patients, most of whom are uninsured or underinsured. And I say underinsured too, because our patient population makes up a lot of folks who are working multiple part-time jobs. So think service industry, restaurants, fast food, right? So a lot of our patients are working in situations where they either can't afford any health options that are offered to them, or because they're working in multiple part-time roles, they're not eligible for full-time insurance benefits. So we accept Medicaid, Medicare, private insurance across the board. We offer a sliding fee scale for those who are uninsured. And a key piece of what we do is we don't sacrifice any quality or integration efforts based on people's ability to pay or cover their cost of care. So ultimately, I think about our work oftentimes as we provide healthcare, we provide behavioral health. We're the largest HIV provider in the region, but I think ultimately those are tools. Ultimately, our goal is really about moving people out of poverty and addressing issues of health equity across the region. So that's why a lot of our services are more wraparound in nature. So we have community health workers, health insurance navigators. We are working with a lot of prevention efforts too. And if you think about kind of medical services that we offer, it's interesting because we're serving the safety net population. A lot of the patients that we're seeing sometimes haven't been to a doctor in 10 years. So we're addressing really acute chronic issues that the acuity only went up over the past few years. But I wanted to kind of put some other context in place to tell you a little bit about why I've chosen to present on some of these things. Is that we've been, prior to COVID, we were doing some change management work. So I came on board in 2019, but prior to when I arrived, there had already been some turnover at the CEO and COO level. And I showed up mid 2019, just in time for the pandemic to start about 6 months later. And so we've been addressing COVID-19 and federally qualified health centers in the state of Missouri and in Kansas, for that matter, have really been leaned on to act as an extension of public health, because in Missouri, we really don't have a robust public health infrastructure. And so we've worked closely with the public health departments to offer COVID-19 testing in pop-up locations all over the region. You probably have seen our team providing vaccinations at the Kansas City public libraries over the course of the pandemic. So the name of the game of the past year and a half was changing and adapting, sacrifice and anxiety, and really dealing with some key challenges that I thought that Heidi and Lynn really highlighted as well, in the sense that, we're really trying to reduce burnout. We're trying to improve retention and recruitment, and I'll share some data with you that really made us think and step back and reevaluate what we're doing. Wanted to improve engagement, obviously, because we had a workforce that was, some of them were at home and or working hybrid and remotely, and some were, especially our patient-facing staff, were at work every day. So we also wanted to make sure that we addressed diversity and equity in everything that we were doing, and then adapting ultimately to new leadership. And then ultimately building trust was a key piece of what we're doing. And I thought it was important to just note, though, healthcare burnout is mentioned a lot, but I wanted to really kind of preface this or kind of dive into the psychology of helping behavior a little bit here, in the sense that burnout isn't really connected to people who are tired of caring or helping. It's more connected to fatigue, connected to not being able to see impact. And I think that's something that's been unique with COVID-19 over the past year and a half. So we're really dealing with complex moral injury of helping in a situation where your sense of efficacy as a helper is really challenged because you're not getting a lot of positive outcomes. Or in our case, sometimes there are so many needs we can't possibly meet based on capacity, based on staffing, the complexity of behavioral health issues that we're seeing in a primary care setting. All of these things are, in some cases, people who are trying to help are vilified for their attempts to help. So I want to make sure that we're not just, when we say healthcare workforce is burning out, they're not tired of giving or nurturing. They're struggling with moral injury, and they're really struggling to see positive impact of the work that they're doing. And so I wanted to just take a moment there to focus that, because that term gets thrown out a lot. So we really started collecting some data to really kind of take a look at ourselves, and be surprised, as an organization who prides ourselves on addressing health equity, looking at making sure that our staff represents the community that we're serving, and all these things. We really, it's easy to get sidetracked and think because you're doing these things that you're hitting the mark, and sometimes you're not. So we saw increase by 30% of growth in staff who stayed less than 1 year. Now, I realize that healthcare has had this challenge across the board. It's not just, we're not unique in that challenge. Nonetheless, we had to do something about it, right? And then 2018 through 2020, we saw larger turnover amongst our Black, Indigenous, and people of color amongst our staff. And that was a huge eye opener for us, especially as we feel like we're an organization that really dives into health equity and is good at that. So that was a hard look at ourselves. And so we recognized we need to do something quickly about that. We also saw something new in 2020 that the organization had never really had before. And that was 14% of our turnover was connected to job abandonment. It was, more times than I'd like to count where we hired someone, they came for new employee orientation, first couple weeks in the job, and then gone, right? So it happened a lot in some of our frontline patient-facing roles, like registration, working at the front desk, medical assistance, things like that. And so this was something we'd never had to deal with before. We also had this dynamic of this either perceived or real divide between the people who had the opportunity to have more flexible work because maybe they work in a management role, they are doing billing, coding, things like that, versus those who are working kind of patient-facing every day. And so it's almost like there was a tale of two cities, and both of those groups required different things throughout the past year and a half. So we were on a mission to really engage and meet those needs. And so from a now what perspective, we started a new strategic planning process in 2021. And so we wanted to make sure that our communication was clear, concise, that expectations, roles, and all of those things were really well defined, because we did have this tale of two cities in terms of our workforce. And so we really grouped everything that we were doing in one of these three strategic priorities. So you'll see these icons all over the place. They're all over the place at work because this is how we're even reporting out information, right? We want to have these shared models of the ideas that everybody who works there can speak to what they're doing around each one of these strategic priorities. So the employer of choice priority was a big one for us in the sense that we knew that if we wanted to be an employer of choice and we wanted to address some of the challenges that I just pointed out on that ouch slide, if you will, we had to make some of those things someone's job, and we had to have some accountability structure around that as well. So we internally promoted two individuals, one to a vice president of training and development, because that was some feedback that we were getting from staff around some of those things were hard skills. Some of them were soft skill trainings that we were getting feedback around, but we really needed to have someone to manage and focus on training and development of our teams. The second one, I'm a behavioral health clinician by background and training. I'm a behavioral science junkie. And so some of you might recall there was a book called Nudge a couple of years ago, right? So a vice president of organizational effectiveness is really our internal nudge unit, right? So it's a change agent person or organization who acts as an internal consultant. Whenever we're trying to do something new or different, this person doesn't have to be an expert in the content, but they're an expert in process and they're an expert in change management. And they kind of consult with internal departments as they are embarking on some type of change or project. We also really engage in a lot of research and data analysis. I mentioned we really asked ourselves some hard questions, and we decided that we really were going to focus a lot of our efforts on leadership and psychological safety, especially in light of the pandemic, because we were doing so many different things. A lot of us, even our leadership team, were taking turns as a screener, checking temperatures for people walking in, things like that, because it was really important that our staff saw us all as one team, even though a lot of us were doing very different things. So some things that worked, and this is where we did some other traditional things. We brought in EAP as necessary, and we had some other things, but I wanted to focus on some things that maybe weren't the obvious. We made a strategic decision to close our operations 2 mornings a month. And part of that is twofold. One was to provide some respite. We needed, I can't tell you the number of times I met a physician or a nurse or someone at the door who was angry already because they had stopped to get gas that morning and grab a cup of coffee and people weren't wearing a mask and just, you name it, they were really frustrated. And so I really wanted to give people an opportunity to have their meetings, to connect with one another, but also to have a break, right? There was this notion of almost, I think earlier, Dr. Baker spoke of, military training. Well, I feel like I saw some elements of this soldier phenomenon, right? This idea of like, I got to keep seeing patients. I got to keep meeting the need and really not doing the things they need to do to take care of themselves, set boundaries and things like that. So we really focused a lot on training and creating those opportunities for respite and connection with their teams. And we really focused a lot of our training on leadership, supervision quality, cultural humility, health equity, self-care and boundaries, and then also effective performance management. Making sure that we've worked really hard to develop some KC care management and supervision ethos, if you will. Like, this is the way we do things, right? We want to make sure that if someone's a pharmacy tech, but maybe they want to go work in case management at some point, that if they switch departments or move in their jobs or career development, that they could have a high degree of supervision quality no matter what department they were working in. Like was mentioned earlier, we focused a lot on tools, right, for collaboration, using Teams, using all these different softwares. We centralize all of our compliance reporting and incident reporting, ways to manage data, just to improve efficiency, because I think someone mentioned around, for someone to be happy at work, they need to both feel mastery and competent. And so we were really trying to focus on both mastery and competency. And some of that was eliminating inefficiencies. Like a lot of folks, we adjusted salaries. We bonused our frontline staff where we could. We offered flexibility where it was possible. So we revamped all of our job descriptions in the organizations to figure out which roles were eligible for to work remotely, which roles were eligible to have hybrid function, and which jobs had to be in person. So once again, that expectations were very clear, and that we were communicating as clearly as possible on roles, who was doing what. And then we really leaned in heavily. We'd had a diversity and equity inclusion committee, but we really elevated it. We brought them to our board meetings. We talked to our board about engagement in terms of thinking about diversity, equity, inclusion as they leaned into recruiting new board members. So we've started some new initiatives around what we call stop, start, continue conversations, where we have small focus groups of staff that are getting together and saying, hey, here's some things that we're doing that we really need to stop. They're not effective. And it's not just around diversity, equity, inclusion, but it's also about patient safety, communication, what have you. So really leaning into new and different ways to communicate. And these start, stop, continue conversations have been a real jumping off point for a lot of really cool creative changes that we've embarked on this past year. Some other tools that we have started and will continue to use moving forward because they've been successful for us is not focusing so much on exit interviews, but focusing on stay interviews. So really understanding the people who that are working here right now. What are we doing really well that keeps you around? And so really trying to engage around the strengths of the organization and build on those things. We also recognize that over the past year and a half, a lot of people who joined our teams were switching careers completely from other fields. We have some English teachers who are working in our grants department. We've got all these other individuals who wanted to do something where they felt like they were making more of a difference. So we've really tried to really provide a framework and give people the language they needed to really engage in feeling a sense of mission, feeling like they're making a difference. And it's easy sometimes, to give lip service, and we all want to say thank you all the time. And I would encourage everyone to continue saying thank you to our healthcare workforce. However, we thought it was really important that they needed to hear stories of positive impact from the patients that they were serving too. And so we've really done a lot of work to try and get patient stories to the forefront. We focused on, as I mentioned earlier, some KC Care supervision ethos, or ways where ultimately we're talking to people about performance management in terms of both support and challenge, right? We want to make sure that we're providing all the necessary supports, tools, training that people need, but we also want them to work to their highest potential and to the if we're talking about healthcare, right, at the top of their licensure as well. One of the interesting things that we found is that a lot of the people who left healthcare in 2020, we started reaching out to them, or maybe they got a job at Amazon during the holidays or something like that. And we recognized that a lot of people who opted out of their job at some point, or left for some reason, maybe it was the grass looked greener on the other side. We actually found that when we reached out to them, a lot of them weren't happy leaving. And so interestingly enough, we've made it now an HR practice that we reach out periodically to people who've left our organization within the last 12 months. And what's interesting is in late 2021, and even I think there's been 6 or 7 people already in 2022, we've rehired people who left for some reason. It was another job, anything else, but they've told us it wasn't what I thought. I really am looking forward to coming back to the culture that I was really engaged with and felt a part of. And so part of that is quick and public responses to feedback. And I said even to toilet paper quality, because that was a complaint that somebody had, is that, hey, the toilet paper is really bad and the restrooms. And so we worked with our facilities director and we got that fixed, and we communicated it out really quickly. So I'm happy to say that in 2021, we had higher representation of staff who were Black, Indigenous, and people of color, and lower turnover rates. We had the lowest turnover margin with that same group of staff, despite increasing the representation organizationally. And then we had multiple rehires in 2021 and 2022. And then the other thing is we're doing these frequent survey monkeys and asking people for feedback. This is one of the most recent ones. So we do these really quick, and it's a way for people to give us anonymous feedback, so they can be really brutal if they want to. And so we asked people on a scale of 1 to 10, is KC Care a great place to work? And so the most recently people said the average was 7. Some of our staff said actually, well, it's actually higher because there were some people who completed the survey and it was a dial from 1 to 10. And some people just didn't move the dial. And I was like, no, let's keep it at 7. We want to stay conservative. But so we're doing better. And you can see we asked people just to give us quick and dirty, a thumbs up or a thumbs down in certain areas, right? So you can see that culture, mission, work-life balance, benefits, flexibility, your coworkers, and we all know that people often don't leave your organization, they leave their supervisor, right? So all of our efforts to focus on supervision were really effective here, because you can see people rated their supervisor extremely high. So obviously we've got some things to work on in terms of pay. We're a safety net organization. That's always going to be a challenge for us. But I also think, and what we're getting feedback on is with the comments that people gave, is communication. Some of that is exactly what I was talking to you about in terms of the tale of 2 cities, right? We're recognizing that we need to have an internal communication strategy for those that are working remotely, those who are in person, because a lot of our clinical staff, they don't check email as often, right? And sometimes they're not even on Teams as much. So really, we're developing right now an internal kind of strategy to address the things that people are saying that we need to do better on or give us a thumbs down So those are some quick hits in terms of taking care of our healthcare workforce and taking care of the people who are taking care of the people. So I really appreciate all the other presenters and happy to answer any questions.
So I can't thank all of our presenters enough. And, you know, when, you know, Pat and Stacy and I sit around and we try and pull together one of these forums, you know, we're never quite sure how, you know, it's going to work out. Is the chemistry right? This was a fabulous session, in part because it was really a celebration of the human individual, you know, and how important they are and what's needed to be able to engage and maximize the commitment and productivity of different people. And so it was just wonderful. I loved the two initial presentations, one from Kim on sort of the researcher perspective, and for David taking out time to share all the work he did with Team Steps. I was really inspired by what, you know, KU is doing to intentionally focus on trying to recognize the needs of individuals in their workforce. And Will, the transparency with which you discussed the challenges you faced and how you overcame them was just fabulous, and really appreciate that. I have questions for everybody, and I would like to encourage others to either speak up, raise your hand on Zoom, or put something in the chat. But I'm just curious, you know, David, for the Team Steps program, you know, it's very impressive how, you know, this gets organized, how you pull everybody together, how you start to implement it. How do you measure, you know, there's a cycle of improving, of sort of looking at the outcomes of the initial efforts after you've launched your program, and somehow it magically feeds back. What are you looking at, and what are you reacting to, and how are you nimbly adjusting some of your approaches to improve teamwork? Because it's hard for me to understand exactly how you're going to measure the success and effectiveness of a team in a rapid cycle fashion, I should say.
Well, I think that's the key. Some of it is rapid cycle, which is ongoing quality improvement. One of the things in the original version, when we created it, we didn't have any resources or instruction around how to measure your initiative, which was added into the current version. I put the link, which is Team Steps 2.0. I don't know if we'll ever get the Team Steps Next Gen. But I think we think about this as a training program. So when we measure and evaluate its effect, right, we look at it in a very Kirkpatrick-like way of evaluating training. And the crux of, I think, what you're getting at, John, is more on the transfer and outcomes. So the level 3 and 4 evaluation criteria, and that's in the planning. So clearly defining the aim that you're trying to improve objectively when you start the initiative really helps ensuring the success and helps with the measurement. So thinking about, and it's been some time where I've worked directly with care workers, but you can think about counts of different things. We can think about delays to this of that in terms of process measures, in terms of ED wait times this could be used for, and how we manage workload as critical outcome measures that we've seen improvement over in our research. So I think having that clearly defined aim, which is the biggest challenge that I from working with folks, right? They kind of think about our culture is going to be better. That's our aim. Well, that's not specific enough. Or our teamwork's going to be better. Well, how are we going to know that? Is really trying to define it in a way you can see it and measure it as critical to all of this. And that creates that feedback loop for rapid cycle too.
I guess, you know, I can understand how you know, could look at, you know, outcomes or adverse outcomes, but a lot of what you talked about was, you know, sort of mutual respect among the team, about backfilling roles, things of that. How do you assess that? I mean, how do you assess the dynamics of team functioning apart from, you know, the shared goal that they're all trying to achieve?
Yeah, so that's tricky. You can definitely develop process measures, right? So that gets into, and you can observe, and that's a lot of work that I did early in my career with United. How do we observe whether or not the air crews are meeting certain standards? And there's all sorts of measurement tools out there to do that kind of observations. One of the studies we did that I was part of looked at that level of transfer in the trauma environment. So we had trained observers observing teamwork in specific traumas. Some areas allow for videotaping traumas, so you could code them afterwards, right? Then you take out the observer phenomenon potentially. You can use simulation to test team process, which is also an interesting concept, right? And there's so much use of simulation either through centers or this idea of in situ simulation, where you bring the simulator into a particular clinical environment and run a scenario. There's a guide. Again, there's all sorts of resources to support this in the Team Steps curriculum. So that's some of the ways that you can look at. Simulation is particularly good if you go back to the original thing I said about people know what to do. People think it's a good idea, they don't do it. So it's a skill base. It allows them to practice these skills and refine it and build trust. One of the key things, right, with teamwork, and I didn't have time to go into everything, is expectations individuals bring to the team situation. And one of the things you're trying to do in Team Steps, because in healthcare, the members keep changing all the time, is create a common expectation of how teamwork is supposed to occur. So we've all been the story I used to, we've all been in teams, and being in teams is not always a good experience, right? Think back to when you were in school and you had to do a school project, right? And those projects were somewhat challenging because there was always somebody who, by Kim's term, was the social loafer, right? And didn't participate. And so we have expectations when we come into those team settings. So Team Steps helps normalize what teamwork should be, what should happen in a team, and creates a better environment to establish trust and confidence among the team members too.
Super. I wonder if, Kim, you might comment, and then Will, who's sort of devoting a lot of energy into sort of revitalizing the teamwork, how, practically you guys are thinking about understanding and measuring and using that measurement to improve team functioning.
I'll jump in real quick, John. Thanks. I agree with David. There are a lot of different ways to look at this. Shelley Ellis already beat me to the punch in the chat box with a measure that I think, and Shelley, you might want to come off mute and you can talk to it better because you've been using this, but this is from University of Vermont, I think, right? It's a measure of relational coordination within teams. Shelley, why don't you jump in?
Yeah, it's actually from Jody Gattell from Brandeis, but
I was close in the right quadrant.
Yep. She's been working on this concept for a long time, and it builds on many of the things that Team Steps, the strategies that are suggested to use in Team Steps, and it just measures. I think it aligns with the 4 components of competencies that Dr. Baker had illustrated in his slide. And so there's a communication subcomponent, shared goals or shared mental model of what you all are doing. So it's the piece that it's not the outcome of what you're actually achieving, it's how your team is relating to each other, and if you can measure whether that's getting better as a process outcome.
And Will, when you address this, Matt Bunty also asked if you could also be a little bit more specific. All the gains you made in spite of the COVID pandemic are really impressive. And so if you could also, I don't mean to, you're never supposed to ask a double-barreled question, but I'm asking you 2 completely different topics to tackle both.
Sure. So from a process kind of measurements perspective and how we measure things, a lot of what we're doing is making sure that, one, the goals are very clear, that we're all working towards, and that we have like key performance indicators that we're all tracking and looking at. The other piece to that, though, is that we've really tried to make it completely transparent that our goal of being a provider of choice is really contingent upon us being an employer of choice, right? If we don't have a relationship and we don't have synergy and good coordination internally as an organization, it's hard to have productivity and retention if you don't have, and we call it internal customer service. We feel like internal customer service is a driver for external customer service. And so we measure some different variables in all of that. And that's also really how we really drive forth the mission of the message of mission, because if you think about it, we have our mission. And then really, if we're doing a good job with that, we're doing internal customer service. Internal customer service impacts your productivity, retention, and ultimately external customer service. And where community health centers do well from a revenue standpoint is not actually seeing multiple new patients all the time. It's actually repeated visits with patients to address chronic illness outcomes, right? And so therefore, when you build a successful team and good patient experience, well, now that patient loyalty is actually what drives revenue and revenue growth in our health center, which revenue growth equals reinvestment in the mission, right? And so we're very transparent with that model, and we share that. It's a visual diagram that we use, and we share that with everyone all the time, that that mission piece is why we do all of this work, because we're trying to reinvest and grow that piece. And so it's twofold from a measurement perspective and this notion of reinforcing the mission and the vision of the work that we're doing with our team.
Terrific. We are out of time. I did just want to ask one quick burning question to Heidi and Lynn about how sort of KU got behind investing in a lot of this infrastructure and financing it, and the support that you got from administration. And I'm always struggling to understand how administration prioritizes what it prioritizes. And this is something they seem to have prioritized. And maybe the answer is obvious, but I would love to hear it from you.
I would say, part of our, formula for, taking the best care of patients is taking and investing in our people. And so our organization very much cares about our people. And I think that's, just as, we have discussed today, just how important that is. So I really think it boils down to that. It's just, we know how important it is that we take care of our people. There's that saying, you have to put on your own oxygen mask first. So it's important that we make sure that we're taking the best care of, our employees, so that way they can take the best care of our patients.
And I think our leadership has been very intentional about communicating with all the staff. We have, it feels like almost monthly town halls, multiple forums where they collect input on what can we do to support you, what is meaningful recognition. There was feedback that our EAP, which, that feels like anytime we talk about distress in the workplace, we have, call the EAP, and there was feedback that the EAP that we were currently using wasn't very helpful. So, they put some work into getting one that was helpful, that would meet the needs of the staff. So there's been a lot of intentional data collection on their part, and they have been willing to listen. And even technology wise, when the pandemic started, we were just switching over to Teams from, I don't remember what we were using there, Skype, I think. And there was, some hiccups with that, and not everyone, for instance, at first could schedule with a phone number, and all sorts of just operational things. But listening to the feedback again, like, we need these things to have effective virtual meetings and all that. It was worth the money associated with having those abilities for operations to continue seamlessly.
Well, I'd like to, thank again all the speakers, and the participants. We really appreciate it, and it's through these efforts that we collectively learn how to deliver better and more valuable healthcare in our region. And so we really appreciate all of your support, time, thoughtfulness, and basically real transparency and sharing your perspective and experiences. And thank you very much. We do have another forum on long COVID on February 17th, and so. We would love to see you there as well. It's going to be a terrific series of presentations, and it's something, unfortunately, we're going to be dealing with for a long time coming. So hopefully it's very relevant to you. Thank you all so very much.